everybody. My name is Claudia Gray. I'm a professor of pediatrics at the University of Cape Town. I have a big private practice in pediatric allergology, which is my passion. And today I would love to talk to you about allergic rhinitis, especially in the context of COVID-19. And thank you very much to the sponsors for inviting me to do the talk. It's very much appreciated. And I would just like to reiterate that these slides are my own, unbiased, and I have no conflicts of interest to declare. Right, so in overview of this presentation, these are the things I'm going to be touching on. It's not particularly long, but I hope it will be of practical significance. So first of all, what's so special about SARS-CoV-2? We all know that, but let's hear a couple of interesting facts. And secondly, some general concepts about allergic rhinitis, just a quick refresher course. And then thirdly, the treatment of allergic rhinitis, which will also be a quick refresher course for most of you. Then come the questions about the association between allergic rhinitis and COVID-19. So question number one is, are allergic rhinitis and COVID easy to tell apart? The second question is, does allergic rhinitis itself increase your susceptibility to catching COVID or the SARS-CoV-2 virus? And thirdly, what about allergic rhinitis treatment? Should we be continuing it? Should we advocate it during COVID-19 pandemics? So let's talk about that first topic. So what is so special about SARS-CoV-2? Well, we've heard this ad nauseum. We all know about COVID-19. I call it the great pretender. It has so many varied presentations, from headache to sinus to chest to pneumonitis to flu-like illness, and we're all familiar with this by now. So what's so different with COVID-19 if we compare it with other seasonal viruses, such as the flu virus, for example? Well, first of all, the R number. If you ever heard Sky News, when we were in the middle of the first wave, we had Sky News on most days in our house. And the R factor, the R number, was this big talk of the town. Well, this is the transmissibility of the virus. How many people would one affected person infect? So for flu, it's about 1.2. But for the COVID-19, the SARS-CoV-2 virus, it's 2 to 6. So the Delta virus is erring more towards the 5 to 6. And apparently the new virus is coming up might even be 5 or 10 times more transmissible than that. So if one person has coronavirus, more people get it than people would get the flu from that person. Secondly, the mortality. So initially we thought the mortality was similar to flu, but it is higher. And even if it's just a couple of point percentages higher, it's significant in the greater scheme of all the numbers all over the world. So whereas flu has a mortality of around 0.1%, COVID has a mortality of 0.4 to 2%, depending on what statistics you read or believe. I believe often we don't really know our denominator that well, because I think many more people have COVID than we realize. But this combination of the R number and the mortality rate makes it a very significant pandemic, right? And we see our pyramids that flu, if one person has flu, over time, the base goes bigger and bigger. But if you compare that with your coronavirus, the base escalates largely and rapidly to this huge number of people in a very short space of time. We've heard about the components of the SARS-CoV-2 virus. We've all heard about the spike protein, especially because that's the protein that's being used in our vaccinations. But of course, we have envelope proteins, membrane proteins, nuclear proteins. And the bottom line is that, like with any other virus, our cells engulf the virus. The virus is pretty pathetic because it can't replicate itself. So it relies on host material for replication. That's its sole purpose, is to survive. Its purpose is not to make people sick. Its purpose is to replicate. And in a healthy immune system, we've taken this virus and our immune system gets going and our infected cells are rapidly cleared. Our antibodies neutralize the virus and we have minimal inflammation and lung damage. But on this side here in a dysfunctional immune system. So this could be a person who's elderly and the immune system is elderly, who's very young, who has an underlying condition which affects their immunity. But every now and again, we also see this dysfunction in young, healthy people who may be missing one or two components of the immune system, which effectively fight the SARS-CoV-2 virus. And if we don't do a good job of getting rid of the viral particles, we get excessive infiltration of our own inflammatory cells, a systemic cytokine storm, setting up a pneumonitis. We can get pulmonary edema, pneumonia, and of course, widespread cytokine release and coagulation defects, leading to damage and multi-organ failure. And this is something, sadly, that we've all witnessed in the past year and a half. So just to reiterate, the vast majority of people have got cold and flu symptoms with the SARS-CoV-2 virus, but the unlucky 15% get a bit of the cytokine storm and the pneumonitis, and the more unlucky 5% can get multi-organ failure, and then this devastating hypercoagulable state, hyperinflammatory state, where the host does most of the damage, and that can, of course, lead to death. We also have our late post-inflammatory reactions, like the pediatric multisystem inflammatory disease or your long COVID syndrome. So those can last a long time or start a long time after the initial virus. We've seen the devastating effect that the spread of coronavirus can have, in that it comes in waves where people are rapidly infected and measures need to be taken, such as lockdown. So we had our first wave in May, June, July last year, our second wave earlier this year, and our third wave, very devastating with the Delta virus more recently, which is now coming to an end. Against that background, let's now get to some nitty-gritty of allergic rhinitis. And allow me to divert just a little bit and talk a bit about the cough reflex, because as GPs, as pediatricians, one of the most common reasons for presentation is a cough, isn't it? And of course, allergic rhinitis could be one such reason for a cough. Now, why is this? Well, our airway is filled with cough receptors at many levels. The top level would be your hypopharynx and your larynx. Then slightly lower than that in the trachea, there are more cough receptors, and then in the bronchi. So if at any of these levels, the cough receptors are stimulated by mucus or by reflux or by infection, then this sets up a response. Our vagal nerve is stimulated, it goes to the brain, it tells our diaphragm and our chest muscles to contract, and we come out with this forceful cough that, just for fun, releases 3,000 small salivary or mucus droplets at a speed of up to 80 kilometers an hour and can fill a 1.5 liter bottle with particles. So now we can see why a cough is such an effective way of transmitting disease. Now, coughs can come from many areas of your airway, and traditionally, we've divided it into our upper respiratory zone and our lower respiratory zone. Upper respiratory, say to the patient, you've got an urti or an upper respiratory infection. The adenoids, the sinuses, the tonsils, the nose, the rhinitis, your tongue, your larynx, croup, trachea, esophagus, all can cause a cough. Then we go on to our lower respiratory system, which essentially is our bronchi and our alveoli. But I'd like to introduce the concept that the upper and lower airways are actually not that divided. We nowadays consider them as a unified morphological and functional unit. And there's lots of evidence for that. And we always say to our patients, actually, guys, this is where the chest starts. So if the nose is poorly controlled, it's one anatomical unit, and often the chest is then poorly controlled too. So this is the concept of the united airway, with upper and lower airways being connected in many types of ways. We come back to allergic rhinitis. Now, This is a reaction which involves the immune system. So we're not talking about an irritant rhinitis, such as when you sneeze with an air conditioner. It involves the immune system, which overreacts to things that really should normally be harmless, mostly air allergens. So a mistake that's commonly made is to think that allergic rhinitis is caused by food allergens. It's not. In 99.999% of cases, it's not milk, it's not wheat. It's usually an air allergen. And it causes the cardinal symptoms of itch, sneeze, congestion, and rhinorrhea, and ocular involvement in quite a large percentage of cases. Allergic rhinitis is not to be sniffed at. It can be a really debilitating condition. It can, of course, lead to local complications such as otitis media or sinusitis because all the ostia are blocked up by swelling and mucus. It can lead to more atopic complications such as a worsening of your asthma if your nose is not well controlled. And lastly, it can have emotional, social consequences, poor sleep, poor scholastic performance because you're itching and sneezing and haven't slept well. When we talk about allergic rhinitis, we are often confronted with pictures such as these, looking at phase 1 sensitization and then phase 2 sensitization. And if you're anything like me, at this stage, I kind of just switch off because my brain is overloaded anyway. So let me try and simplify, and after my name, I shall call it Gray's Anatomy. So this is a depiction of allergic rhinitis when we confront an allergen that we've confronted before, and we've set up an antibody response to it. So the antibodies sit on the mast cells, and the allergen cross-links these IgE antibodies. So what happens next? Well, it causes the mast cell to degranulate, and first of all, to release preformed mediators. We know histamine, we know leukotrienes, and also, of course, neuropeptides. And this causes rapid neuronal activation and leakage from the vasculature, causing itching, sneezing, and even nasal congestion. But we also have other cytokines involved that are sometimes ignored in our general overview, such as interleukin-13, which leads to mucus hypersecretion. And important to understand is that other cytokines, such as our T helper cell type 2 cytokines, IL-4 and IL-5, can actually set up a prolonged response by recruiting cells to the site of the inflammation. And this leads to sustained inflammation. So if I'm grass pollen allergic, which is a big problem at the moment, and I breathe in grass pollens, I will get almost immediate effects of itching and sneezing and rubbing, but I may still have effects 2 hours later or 3 hours later, or indeed the entire day, because my interleukins are setting up a sustained inflammatory response. When we classify allergic rhinitis, we can either classify it by etiology, so what's causing it. It could be seasonal, like grass pollen or tree pollen, or it could be all year round, perennial, like house dust mite or mold or animal dander or cockroaches. Another way of classifying allergic rhinitis is using the ARIA classification, and ARIA stands for allergic rhinitis and its impact on asthma. And the ARIA classification uses the duration and the severity of symptoms. But by its very nature, allergic rhinitis and its impact on asthma, it reminds us that actually we are really integrated with the nose and the chest, and the chest starts here. I always say to my patients, this is where your chest starts. That's where we need to start working. And with the ARIA classification, we classify allergic rhinitis into intermittent or persistent, mild or moderate and severe. And you can have a good look at these slides at your own leisure, but essentially intermittent is less than 4 days a week or less than 4 weeks in a row. Mild would be normal sleep, no trouble with daily life, but a bit of itching and sneezing. But as soon as you hit sleep disorder, disturbance of your sport or your daily life, or symptoms that are irritating you at work or school or are really troublesome, we're really already in the moderate to severe category. And this affects the treatment that we choose. So let's talk a little bit about treatment. Allergic rhinitis, irritating as it is, can actually be very well controlled given the right treatment. When we look at treatments or medications in general, we need to look at them from many perspectives. First of all, efficacy. How well do they work? Secondly, safety. What side effects are a possibility? What's the risk-benefit ratio? Thirdly, can the medicines, the way they're given, their ingredients, promote compliance? And fourthly, how cost-effective is the treatment? And all of these pillars need to be taken into consideration when choosing the right treatment for the right patient. When we look at the ARIA classification and the treatment, I want you to focus on two things that are used really early on. So for anything more than moderate or anything persistent, an intranasal steroid is indicated. So it's indicated early on in the disease and in any persistent allergic rhinitis. Intranasal, local chromones, we don't really use here. Intranasal decongestants, I beg to differ. I think we can only use them for 5 days at a time because you can get a terrible rebound. But local or oral antihistamines, non-sedative, not the old-fashioned Phenagans or other sedating antihistamines, also come in very, very early in our algorithm. So let's focus on intranasal steroids and local or intranasal antihistamines. So when we look at an antihistamine, which part of our algorithm does it block? Well, only histamines, or indeed it stabilizes the mast cell so it doesn't release as many histamines. So it's got quite a narrow effect. It's very, very effective on your rapid neuronal activation, your itching, your sneezing. When we look at an anti-leukotriene, it's also quite a specific effect on the leukotrienes. Decongestants, also they really act mainly on your neuronal activation. But when we look at intranasal steroids, they have a very broad effect. So they can affect both your immediate actions and reactions and symptoms and your delayed symptoms, because they affect your histamine release, your leukotriene release, and your interleukin release. So they can have a more sustained and broad effect. So that is why when we look at a table of allergic rhinitis symptoms and ocular symptoms, the steroids probably feature as best overall. They're good for itching, they're good for sneezing, they're good for rhinorrhea, they're good for nasal blockage, and they help a little bit with eye symptoms as well as smell. The antihistamines are a close second. They're great for sneezing, they're great for itching, they're good for discharge, they're okay for nasal blockage, but not as strong as the intranasal steroids on the nasal blockage front. Not so good for smell disorders, and they can have a little bit of an effect on the eyes, of course. So let's remind ourselves why steroids have such a broad effect and also how antihistamines work. So going back to 4th or 5th year medicine, steroids are, of course, molecules that work on the level of the DNA. So they're quite phenomenal, really. The glucocorticoids penetrate your plasma membrane. That's depicted over here. It binds to your glucocorticoid receptor in the green there. That complex translocates into the nucleus and attaches itself to an area in the DNA called your steroid responsive gene. And here it acts to activate anti-inflammatory action and to suppress or repress pro-inflammatory genes. So it takes a while to work, but when it works at the level of the DNA for a very broad effect. So the strengths of an intranasal corticosteroid are its multiple sites of action and its prolonged action. Its weaknesses are that it takes a bit longer to work, because first of all, it has to get into the nucleus and into the DNA and affect the subscription. So it takes 3 to 6 hours to start working, and the maximal effect actually only occurs after a few weeks of regular use. Let's turn our attention now to antihistamines, the other main form of treatment of allergic rhinitis. And I remind you that histamine is all over our bodies. It's an important cytokine and an important messenger at many levels, including the brain, the gut, etc. And we have 4 types of histamine receptors that alternate between active and inactive forms. Histamine itself, when it binds the histamine receptor, stabilizes the active form. So it's an agonist. Antihistamines bind to the histamine receptor and stabilize it in the inactive form. So they don't just block it off, but they're called an inverse agonist. So if we look at this in a picture, pure histamines on the left-hand side there go onto the histamine receptor and let the histamine receptor work in all its glory. But an antihistamine competes with the histamine, it binds to the receptor, and it makes it inactive. That's why we block our histaminergic effects. The advantages of antihistamines are that it's got multiple antihistamine actions. The disadvantage, it doesn't act on other cytokines and chemicals. Another advantage, rapid onset of action. So when people have anaphylaxis or a mild, or anaphylaxis, we should get adrenaline, but if they have a mild allergic rhinitis or allergic reaction, pardon me, say to food or to peanut, and they break out in hives and swelling, an antihistamine works fairly smartly and fast. So the onset of action is within minutes. And with local antihistamines, so topical antihistamines, it can actually act even faster. And the other advantage of your topical or local antihistamine is that we circumvent any systemic effects, because remember, some of our old-fashioned antihistamines have many negative effects. The newer generations are better, but some people can still get fatigue or dry mouth, etc. from them. The reality is, with allergic rhinitis treatment, that over 70% of patients with moderate to severe allergic rhinitis require multiple therapies to achieve system relief. So we have some exciting new combination treatments, such as a combination of intranasal antihistamine and an intranasal corticosteroid, all in one spray, that are great because this really takes this problem of needing multiple treatments and putting them into a single bottle. This is a bit difficult to see, but the bottom line is that such combination treatments have shown greater improvement in nasal symptoms than monotherapy with corticosteroids or with antihistamines. So there are some advantages using our sort of newer paradigms in allergic rhinitis treatment of combination sprays. The advantages are, first of all, that there's direct application to the mucosa at the source of inflammation. So it really acts directly where it's supposed to act. Secondly, because we have 2 different molecules, we have an additive effect with different mechanisms, making a lovely broad action. For example, antihistamines rapidly reduce nasal symptoms of itching, sneezing, rhinorrhea, whereas an intranasal steroid is particularly effective in nasal congestion. There's also another advantage to combination sprays. Remember that intranasal steroids take a few days to really take effect, and some patients who are particularly impatient and want action now might say, oh, this is not working on me, I'm going to ditch it. But the advantage of a combination is that the antihistamine component works fast. And then you have got the prolonged sustained reaction of the corticosteroid to follow. Other advantages are that a single device provides more uniform distribution of spray instead of having to use 2 different devices or 2 different sprays. There's a low prevalence of local side effects and, of course, excessively low prevalence of systemic side effects. And the single device most likely will promote compliance. And if we go back to our slide on what makes a good treatment, compliance is a very important part of choosing a treatment. Now we are on our home stretch. So we're going to go back to the 3 questions. We've learned about COVID, we've learned about allergic rhinitis. So now we come to our 3 questions at the end. So question number 1, are allergic rhinitis and COVID easy to tell apart? Well, is this the truth or is it a myth? I think at the beginning of the pandemic, which was last year, March, April, May, we were pretty smug in saying, this is COVID, this is something else. And these lovely tables came out of the Center for Diseases Control in the USA fairly early on, saying COVID, yeah, it causes fever, headache, body aches, but no, it doesn't cause a runny nose, doesn't cause sneezing. It certainly really doesn't cause much of a sore throat. So it's easy to tell apart from allergic rhinitis, because in rhinitis, we've got that runny nose, that sneezing, that itching. But over time, I think we've learned our lesson, especially with the Delta variant. You guys must have seen it. I've certainly seen it in glorious fashion, that a lot of the COVID patients presented like an allergic rhinitis with an itchy, sneezy nose. And some of them went on to have severe or even fatal disease. So with the Delta variant, we've seen headaches, runny noses, sneezing, sore throats. It really can mimic allergic rhinitis. So is it easy to tell apart allergies and COVID-19? The answer is no, that's a myth. They can be very, very similar. Does allergic rhinitis increase your chance of catching COVID-19? So does it increase your susceptibility to COVID-19? Now, of course, there was a big initial concern that allergic diseases such as asthma, rhinitis would make you more prone to getting COVID-19. But actually, this is not really borne out in clinical practice, and I'll show you some graphs. So this is it's like a Christmas tree graph, which is quite difficult to see, but the bottom line is it looked at a population of COVID-19 sufferers and how many were asthmatics and how many were non-asthmatics. And the asthmatics were actually less likely to get COVID. So this was a bit of a surprise. Of course, very bad, poorly controlled asthma, as with any chest disease, would be a risk factor. But the majority of people with mild to moderate asthma are not at greater risk of COVID-19. And we can probably extrapolate that to allergic rhinitis and as well. And in fact, there have been some proposals that it could be the opposite. In fact, proposals that asthma or allergies could actually reduce your risk of catching COVID-19. What an interesting fact. And that's mainly because the biomarkers of allergic inflammation actually suppress ACE2 receptor expression. So we've all learned that the SARS-CoV-2 virus likes to attach to our ACE2 receptor. But in fact, if you're very atopic, you have a reduction in ACE2 receptor. So it could be protective. The eosinophils could also be protective. Interleukin-13 could be protective. And this chart here shows us that patients with asthma and medium IgE sensitization, asthma and high IgE sensitization, if you pull the line across, apologies, they have a lower expression of the ACE2 receptor. So the bottom line is no, having asthma and having allergic rhinitis per se, especially if they're well controlled, does not make you at a greater risk of COVID-19. But poorly controlled allergic rhinitis is a problem. Why? Because we touch our nose all the time. We rub our nose, we sneeze, we itch, we fiddle with our masks. And all of those factors, of course, can increase your surface or your droplet to nose, droplet to eye contact, and thus, in theory, increase your chance of giving yourself or even others the virus by coughing and sneezing. So it's all about the disease control, which is why a talk like this is especially important to reiterate to our patients that, especially now, please take your regular treatment. So let's get on to that. What about allergic rhinitis treatment and COVID? Is it contraindicated? Should we not be taking our intranasal steroids? Do antihistamines interfere? Well, the Center for Disease Control and the American Academy of Allergy and Clinical Immunology have all emphatically stated that the following medications are safe during COVID-19: inhaled steroids, oral steroids if you're already on them, biologics, nasal sprays, antihistamines, and even our desensitization injections that our patients are on, for example, sublingual immunotherapy or injectable immunotherapy. And interestingly, it's actually borne out that a lot of allergic condition or asthma treatment has actually been beneficial for the treatment of COVID-19. We've heard about the dexamethasone, that in critically ill patients, you can see from this graph, it reduces the mortality quite significantly. More recently, we've had studies showing that inhaled budesonide is actually quite good if you've got mild to moderate COVID. And in a study in almost 2,000 elderly patients, it was shown that their recovery was far quicker if they were put on an inhaled steroid. Ciclesinide is the same. And in fact, ciclesinide's been hopelessly out of stock recently because people have caught on to the fact that it might help treat mild to moderate COVID. And in a small study, it showed that ciclesinide increased viral eradication and reduce the progression to respiratory failure. How interesting. But that's all asthma treatment. What about allergic rhinitis treatment? Well, we know that the site of entry of the SARS-CoV-2 virus is highly expressed in nasal epithelial cells. So what about nasal steroids? Well, pretty much hot off the press, only published online so far in September in the Journal of Allergy and Clinical Immunology. We have the statement that intranasal corticosteroids are associated with better outcomes in COVID-19 disease. It was shown to have a lower risk for COVID-19 related hospitalization, admission to ICU, and even in-hospital mortality. But of course, this needs to be followed up by further studies. But the bottom line is that all of our treatments are safe and probably even an advantage if you get COVID-19. So we've talked about what's so special about SARS-CoV-2, and I remind you of that steep pyramid of transmission. We've talked about allergic rhinitis and its treatment and the fact that combination treatment is very often needed. We've talked about allergic rhinitis and COVID really mimicking each other. We've talked about allergies not really increasing your susceptibility to disease, but the fact that your allergies have to be well controlled. And we've also talked about the treatment of allergic rhinitis, how safe and even beneficial it is. So let's do some take-home messages. Allergic rhinitis is common. It can be debilitating, but it can be treated well. COVID-19, especially the Delta variant, can certainly mimic allergic rhinitis. Poorly controlled allergic rhinitis may increase COVID-19 spread because of fiddling and touching and itching and sneezing, but atopy or allergies per se are not really a risk factor. We've also heard that allergic rhinitis treatments may in fact protect against COVID-19. So we all should be going and buying our intranasal steroids now. It is therefore currently especially important that allergic rhinitis is well controlled, and many treatment options exist, but most patients need a combination of sorts. So we are very excited to have combination sprays such as those with an intranasal steroid and a mast cell stabilizer or antihistamine. They're a very good option for quick and sustained control. And with that, I would like to thank you very much, and hopefully there will be time for some questions.